Okay, thank you, Paul. Can you see my screen?
Yes, we can see it.
Okay, we are going to talk about the basics of hepatitis and also about the blood-based oral self-test. So in this module, we are going to understand the triple elimination, which is EMTCT agenda for HIV, syphilis, and hepatitis B virus. When and why to screen pregnant and breastfeeding women for hepatitis B in Kenya, introduce rapid antigen hepatitis B service antigen rapid testing procedure, interpret, document, and act on the results within the PMTCT cascade. Then apply national WHO guidance on maternal and viral prophylaxis and newborn hepatitis B birth dose. Then we'll touch a little bit on the data management, reporting, and supply. In Kenya, triple elimination of vertical transmission policy, it has some guidelines. Those are the guidelines which we use in this country. And this triple elimination is captured in the Kenya National Guidelines for the Management of HIV, STI, and Viral Hepatitis. The goal is to raise a generation born free of HIV, syphilis, and hepatitis B virus. That is why we are calling it the triple elimination, because we are eliminating the three diseases, the HIV, syphilis, and hepatitis B. It is stated in ANC service delivery to do multiple tests, care, and treatment. The key pillars here are the primary prevention, timely testing, effective treatment or prophylaxis, and timely data reporting through KHIS. The MTCT of HIV, hepatitis B virus, and syphilis, significant causes of perinatal morbidity and mortality. The three diseases, they cause perinatal morbidity and mortality, whereby perinatal hepatitis B infection has a high risk of chronicity and future hepatocellular carcinoma. As we know, it causes
Mwisa?
cancer of the... Yes?
It's not moving. You are
What is
still
not
on
moving?
the first, the slides. We are still on the first slide and we are hearing a lot that you're speaking that is in the preceding slides.
What of now?
Yeah, that is okay now.
Okay, we have gone through those. Tumefika hapo sasa. Triple EMTCT aligns with Kenya's integrated PMTCT and MN maternal neonatal child health priorities. Failure to detect and treat hepatitis, HIV and hepatitis B among breastfeeding women results in high HIV, hepatitis B viral loads and increases risk of vertical transmission. The transmission of diseases similar, that is during pregnancy and delivery. HIV MTCT rate vary between 20% and 35% in breastfed infants, or 15 and 20% for non-breastfed infants minus intervention. So it is high in breastfeeding infants, but lower in non-breastfeeding infants. And it can be reduced to less than 5 with effective interventions. The regional epidemiology, this is how it presents. In the African region accounts for 63% of new hepatitis B virus infections. 18% of newborns in the region receive the birth dose vaccination. Africa accounts for 70% of the global hepatitis B cases found among children younger than 5 years. And in 2019, only an estimated 2% of persons infected with hepatitis B virus were diagnosed and only 0.1 were treated. So the figures are very low, 2% and only 0.1 were treated. That is very low. That is why the country has shifted to triple elimination. This is how it presents the epidemiology in our country. You can see the high burden areas. The ones in red around the Turkana, yes, and the low burden areas with 0.1 to 1.8, that is eastern north. Migori, Baringo is at 72.72%, no, 11.9, Migori 10%, and Turkana 16.8. Highest prevalence counties. The higher burden is among 45 to 49-year-olds, whereby 8.5% versus to 24-year-olds, 1.5%. And it is higher among pregnant women, 4.2, adults 4.7, those who are living with HIV. Then men is 3.3 and 2.8 among women. The rationale of triple elimination is that they are transmitted sexually and vertically from mother to infant. The three diseases are transmitted sexually and vertically from mother to infant. They can cause significant maternal and child morbidity and mortality, and they are often silent with long latency period, and infected mothers may be unaware and have no symptoms. It can be identified during ANC and treated to prevent vertical transmission. The viral hepatitis is grouped into A, B, C, D, and E. And the grouping is based on route of transmission, whereby hepatitis A and E, they are transmitted through contaminated foods and water, that is the fecal-oral route, and result in short-term acute infections. Then hepatitis B, C, and D, they are bloodborne and result in lifelong chronic infections. Hepatitis A and E cause acute, that is self-limiting infection. What we mean by self-limiting infection is that the immune system can clear the virus itself without interventions of prophylaxis. Then hepatitis B, C, and D may lead to long-term chronic infection and death. And all of them, the A, B, C, D, and E, cause liver inflammations. This is a chart still explaining the same. Hepatitis A, contaminated food and water is the mode of transmission. The vaccine, it has a vaccine, yes, but treatment, no. Hepatitis B is mode of transmission is contact with infected blood, sexual intercourse, and mother to a newborn. It has a vaccine, and treatment is there, but a long-term treatment. Hepatitis C, contact with infected blood is the mode of transmission. It has no vaccine, but treatment is there. The hepatitis D, which is the Delta, for you to get infected, you must already have hepatitis B. Then you come into contact with infected blood, sexual intercourse, and mother to a newborn. Then get the hepatitis B vaccine. That is what can be given if you have hepatitis D, but there is no treatment. When hepatitis C is transmitted through contaminated water, it has no vaccine and no treatment. What is hepatitis now? B. Hepatitis B is a viral infection that can cause serious liver disease and even liver cancer. The modes of transmission of hepatitis B are direct blood-to-blood contact with an infected person, mother to child during birth, household contact, sharing hygiene equipment like razors, toothbrushes, and earrings, healthcare exposures like the needle exposures, blood spills, then tattoos, piercing, barbers, watu wa kinyozi, scarification, circumcision practices can also transmit hepatitis. Through sex, it is transmitted through direct contact with sexual fluids of an infected person, and unprotected sex, there is a risk during any type of sexual contact. Of point to note is that although hepatitis B can infect fetus in utero, this is rare. Transmission generally is associated with antepartum hemorrhage and placental tears. Symptoms. Less than 10% of people infected with chronic hepatitis B have symptoms, and if symptoms occur with chronic hepatitis B, they can be a sign of advanced liver disease. These include losing your appetite, weakness or fatigue, headache, hives, joint pains, pain in the right side of the abdomen, nausea and vomiting, dark urine or pale poop or stool, fever and jaundice. The risk factors associated with hepatitis B infection. One is HIV infection. Age 45 to 54 years, that is the gap yenye inakuwa affected sana na hepatitis B. Polygamy, that is due to multiple sexual partners, lack of formal education and poverty, cultural practices, FGM, tattooing, families with a person with hepatitis B virus infection, sharing of needles, and living in high prevalent regions. Then the populations at risk are healthcare workers, individuals, some are people aged between 45 to 54 years, they are at risk. People in closed settings, that is refugees, camps, prisons, nursing homes, children homes, newborns of mothers with hepatitis B virus, key populations, the MSM, the female sex workers, the PWID, the transgender, and the people living with HIV. Patients undergoing transfusions and dialysis are also at risk. Although hepatitis B can be prevented with a vaccine at birth, not all babies receive the vaccine. Many pregnant women do not know they are infected and unknowingly transmit the virus to their babies. Without the vaccine, most of these will develop into chronic, lifelong infections. But the good news is that there are treatments called antivirals that can effectively control the virus and prevent liver damage. Facilities with CC clinics, you know the drug called TDF, tenofovir. That is the drug used to cure hepatitis B. Then now we move to the kits, where our lab work now begins. I hope all facilities received this kit, the Abbott kit. Ile inakaa tu ililetwa na KEMSA some 2-3 weeks ago. So biosafety and infection prevention control, that is IPC. Standard precautions are hand hygiene, PPE, safe sharp sampling, use plunger-resistant sharps containers, segregate infectious waste, environmental cleaning or disinfection of testing area, and post-exposure management for facility policy. The BioLine kit, the Abbott one, hepatitis B service antigen test overview. This kit is an immunochromatographic rapid test for the qualitative detection of hepatitis B surface antigen. The sample types used here is whole blood, serum, or plasma. And the sample volume is 100 microliters. The time to result is 20 minutes, and the storage is 1 to 30 degrees centigrade. And it has a shelf life of 24 months. Components and materials. The kit contains has 30 test devices, each with a descant in individual foil pouches, and the one instructions for use, the IFU. Materials required but not provided: micropipette, disposable tips, pair of disposable gloves, timer, pen, biohazard box, and a disposable bin. Storage and stability. You note that you bring the test device and specimen to a temperature between 15 to 30 degrees centigrade prior to testing. Keep away from extreme heat and humidity. Do not freeze test kits or reagents. Full effectiveness of expiry date is under ideal storage conditions. Stability of kit components is guaranteed until expiry date. Do not use any components after expiry date. The BioLine hepatitis service antigen test is intended use and target population in Kenya. This is a kit for in vitro diagnostic use only. The population of interest are pregnant women attending ANC. In settings with high hepatitis B prevalence, vertical mother-to-child transmission of chronic hepatitis B is the major mode of transmission along with early childhood infection among those who have not been vaccinated. This test is not suitable for diagnosis of early infection or blood donation screening. To explain on that slide, these kits, the Abbott kits, were supplied by NASCO through KEMSA only for ANC. They are targeting the ANC clients. But as our county, we buy hepatitis from meds. There are some kits we receive from meds. So we can also use the test kits for diagnosis, but not for blood donation screening. The test principle: when the test device is removed from the foil pots, neither the test, that is the T line, nor the control line are visible in the result window. The patient sample is handed to the specimen well, then the sample migrates along the test strip. The principle is a lateral flow immunoassay which captures antibodies which bind into hepatitis B surface antigen. Then a visual line indicates presence. A visible control line is required to indicate a test result is valid. It works the same way as the other kits, the rapid test kits we have, and the principle is almost the same. The test procedure is you open the package and look for the following: test device with descant in window foil pot, instructions for use. Then carefully read the instructions for using the BioLine. Look at the expiration date on the back of the foil pots. If the expiration date has passed, use another kit. Open the foil pot and look for the following: the test device, the descant, then label the device with the patient identifier. Take 100 microliters of serum, plasma, or blood specimen using a micropipette. Dispense 100 microliters of serum, plasma, or whole blood specimen into the specimen well labeled S. Interpret test results at 20 minutes and do not read test results after 20 minutes. It is 20 and 20, no exceeding. Later readings can yield false results. Test result interpretation. Non-reactive result: presence of only the control line within the result window indicates a non-reactive result. A reactive result is the presence of the test line at T and control line at C within the result window, regardless of which line appears first, indicates a positive result. Caution: the presence of any test line T, no matter how faint, indicates a positive result. Invalid result: if the control line C is not visible within the result window after performing the test, the result is considered invalid. Instructions may not have been followed correctly or the test may have deteriorated. It is recommended to read the IFU again before retesting the specimen with a new test device. Quality control, QC. The kit has a test line T and a control line C on the surface of the device. Neither the test line nor the control line is visible in the result window before applying a specimen. The control line is used for procedural control and shows only that the active ingredients of main components on the strip are functional, but is not a guarantee that the specimen has been properly applied and does not represent a positive specimen control. QA and troubleshooting: you avoid incorrect specimen volume, wrong buffer, early or late reading, and you avoid immobilized or clotted samples. Weak test line interpretation, any visible test line is positive. High invalid rate, wait to check. What to check when you have high invalid rate is the storage, the timing, and the volumes of the buffer and the sample. Stockouts, if you have stockouts, you follow the national supply chain workflow and communication with NASCO or KEMSA. Implementation tips tailored to Kenya. You integrate hepatitis B into ANC testing with HIV and syphilis during the ANC profile. Set up referral for hepatitis B DNA testing where available. That is using the tiered networks. Then you coordinate maternity and KEPI for immediate hepatitis B birth dose within 24 hours, including weekends and holidays. The baby should be given an hepatitis B dose within 24 hours after birth from an infected hepatitis B positive mother. Track missed BD and implement catch-up strategies for out-of-facility births. Documentation, hepatitis B screening and positive results are recorded in MH 405, that is the NC Registers version 2023, and they are reportable elements in MH 731. But for the lab, we'll be reporting the FCDRR, the MH 643B, where we report our HIV test kits. There is still a column for the hepatitis B kits. That is where we'll be reporting our consumption on monthly basis. And we are currently not collecting hepatitis B data in MH 333, that is maternity register, and the postnatal register, MH 46. We are done now with hepatitis. I want to do a short presentation on the blood-based HIV self-testing. The global targets, everybody, I hope everyone is aware of this, the 95, 95, 95, and the lab we feature in all of the 95s. One for HIV diagnosis, we feature there as the key people in testing. When it comes to treatment, there are some baseline tests we do as a lab. When it comes to viral suppressions, we are the custodians and also the people involved in taking the viral samples. So the epidemic in Kenya for HIV, you can see MAKUENI is number 27 at 2%. And Wajir at 0.1, the lowest, while the highest is Kisumu at 11.7%. And diagnosed are primarily key populations and their partners of people living with HIV and the STI patients. So the key updates in HTS guidelines under review, these are guidelines now under review. The HIV self-test, if it is reactive, you refer for retesting before ART initiation. You cannot initiate ART using the self-test. The client has to be retested before ART initiation. If it is non-reactive, you initiate preventive service, which is the PrEP. The kit, and it has been supplied in our facilities. It goes by the trade name Check Now. And this is how the performance evaluation in Kenya, how the kit performed during the evaluation before it was rolled out by NASCO to our facilities. It has a sensitivity of 99.8% and specificity of 99.3%. And the accuracy of end user interpretation, participants and HTS provider interpretations have a kappa statistic of 0.9986. Usability and user experience, over 90% reported is in understanding instructions. The instructions are very simple to over 90% of the people who are involved in the survey. collecting blood and interpreting results. Then 94.3 considered the test suitable for home use. 95.1 demonstrated strong user acceptability. And 12.3% expressed difficulty with blood collection. The number is a bit low, 12.3. Ndio walikuwa na shida ya collect the blood sample. The description of the kit, it is a single-use in vitro rapid immunoassay that uses a blood sample for the qualitative detection of antibodies to HIV-1 and 2. It detects both HIV-1 and 2. It is a blood-based third-generation HIV test, self-test, and it is an invasive kind of test intended for HIV self-testers. And a point to remember that is HIV self-test kit should not replace any kit in the HIV testing algorithm. The HIV self-test complements the HTS algorithm. You should not use this kit either to replace screen, one-step, standard queue, or fast response. The psychosocial support concerns you as a provider. The points to note when you are issuing the self-test kit, the blood-based self-test kit to the client. And these points you should address as a provider. The fear of a positive result. The solution is you remind yourself the self-test is not a first step. Confirm a clinic and get a support for treatment if needed. Anxiety about doing the test correctly. Read instructions slowly, follow pictures, or watch a demo video before starting. Emotional stress if testing alone. The solution is you choose a safe, calm place. If possible, have a trusted friend or a counselor nearby. Worry about next steps. The solution is you keep an hotline or helpline numbers ready for advice and support. Gender issues, women fearing blame or violence from partner. The solution is you test in a safe and private setting. Share results only if you feel safe, and you seek support from GVB services if at risk. Then men avoiding testing due to fear of weakness. Solution is you remember self-testing is an act of strength and responsibility. Seek peer support groups for men. Then young people fearing judgment by parents or partners. Solution is you use youth-friendly centers or hotlines for confidential guidance. Keep results private unless you choose to share. Stigma and discrimination, that is feeling worthless if you have self-stigma. You remind yourself that HIV is treatable with care. You can live a full, healthy life. Seek counseling if needed. Community myths and misinformation. The solution is you rely on health workers, official hotlines, or trusted sources, not rumors. Then the procedure for check now. To ensuring reliability of results or quality assurance before you test, pre-test, QA. Use only approved kits, that is the WHO and the Ministry of Health approved kits. Check expiry date, store in a cool, dry place. Wash hands and prepare clean, well-lit space. Ensure privacy to stay calm and focused. While testing, follow instructions step by step. Use the right amount of blood, that is blood or oral fluid. In undress lengine oral, but for our part, we are dealing now with the blood-based. Then you add buffer correctly if required. Use a timer. Control line must appear. It shows the test is valid. Ensuring reliability of results, quality assurance after testing. Read result under good light. Do not read after the time limit and keep your result confidential. Follow next steps as guided by the algorithm. And this is the algorithm whereby you perform a HIV self-test using approved self-test kit and interpret the results. If it is reactive, your client is advised and referred for additional testing as per the national testing algorithm and linked to appropriate HIV prevention or treatment services. So if in Mekunja reactive, you refer the client to be tested using the normal testing algorithm in our facilities in HTS and the other testing points. If it is non-reactive, the client to be linked to preventive HIV prevention services and recommended retesting as needed. A reactive HIV self-test results always requires additional HIV testing according to the national HIV testing algorithm. This kit is to be used to detect antibodies to HIV-1 and 2 in blood sample. And that is how it appears. Hata hiyo cover inakaa hivyo. So service provider instructions for blood-based HIV self-test before distributing the kit to clients ensure the following: that the client is eligible to conduct HIV self-test. That is, must be 15 years and above and voluntarily wants to test. Don't issue to 15 years and below. It is 15 years plus. Explain to the client and voluntarily, not the word voluntarily. Msipe watu hivi, don't force it to push, don't push to clients. You just explain to the client, then voluntarily akiamua kuchukua, just give the procedure and issue. Explain to the client that the blood-based HIV self-test is for screening only, and a reactive result must be confirmed in a health facility. Check kit expiry date and ensure the kit seal is intact. Provide kit to the client and the instruction leaflet. Confidentiality and safety, that is IPC, and advise the client to dispose lancet and test materials safely. Keep all client information confidential. Linkage to care, you give directions to nearest confirmatory testing site. You have to give the site, the facility to the client, mahali ataenda for further retesting. Then share referral cards or hotline numbers with that facility and offer follow-up support if client agrees. You do the follow-up. Instructions to the clients: wash hands and ensure a convenient and well-lit area for testing. Open kit and confirm contents. Then you clean the finger, prick with lancet, and collect blood using pipette as per the kit instruction. Then you add blood to test device and you add the buffer. Wait for 15 to 20 minutes and interpret result. 1 line is negative, 2 lines reactive. That is a possible. It is a possible HIV positive, not confirmed. It is possible. No or unclear line, it is invalid. You repeat the test and do not read after 30 minutes. Waiting time is 15 to 20, but do not exceed 30 minutes. Kit components, we have 1 test device, 1 buffer, 1 specimen dropper, 1 safety lancet, 2 alcohol pads, 1 plaster. After you prick yourself, unafunga nako ka elastoplast. Then instructions for use, items required but not supplied. It is a timer and a tissue. So the client needs a timer and a tissue. This is the procedure, graphical. In a diagrammatic explanation hiyo tumepitia. Just note that you choose the ring finger or the middle finger. Hizo vidole mbili ziko hapo katikati. And you avoid a dominant hand. So result interpretation is 1 pink or red line of any intensity at the letter C control, but no pink or red line at t-test, that is a negative result. A reactive or a positive result is 2 pink or red lines of any intensity at control and at letter T, that is a positive. Invalid, no pink or red line appears in the device window at letter C, irrespective of whether or not a pink red line appears in the window at t-test, that is an invalid. Common challenges and errors users may face and troubleshooting is using too little or too much blood, and the error for using too little blood is invalid or a false negative. When you use too much blood, it is flooding and unclear results. Troubleshooting, you use the provided lancet and follow instructions carefully. Collect just enough blood to reach the marked line or fill the sample area. Touching the sample by mistake, contamination, the error may cause false results or invalid test. Troubleshooting is you wash hands well, dry them completely, and avoid touching the absorbent sample area. If contamination happens, discard the test and you start afresh. Reading the results too early or too late, the error is reading too early is false negative. Reading too late, you get a false positive due to drying. And troubleshooting, always use a timer or a clock. Read results exactly at the time stated in the instructions, e.g. 20 minutes. Do not read before or after the specified window. Not understanding if a faint line means positive or negative, the error is misinterpretation and there is unnecessary worry or false reassurance. Troubleshooting is any visible line in the test area, even faint, should be considered positive. Refer to the kit's instruction leaflet. If unsure, repeat the test or seek confirmation from a health facility. Safety tips, always wash hands before and after the test and never reuse the kit or lancet. Use once only. Put used kit parts and lancets into plastic bag or container before throwing away, and you keep test kits away from children. User acceptability, it is easy to use. There is no skills needed. Clear step-by-step instructions with pictures. It can be done at home or anywhere private. Speed and convenience, results are read in just a few minutes. Saves time, no need to wait at the hospital or clinic. It is helpful for people living far from health facilities. Privacy and comfort, you can test yourself privately without others knowing, and reduces fear of stigma or embarrassment. Then this is communication, effective communication for HIV testing, whereby we have the 7 C's, the correctness, the courtesy, the clarity, the correctness, concreteness, consideration, consensus, and completeness. The role of healthcare workers in engaging local leadership, inventing partners, healthcare workers, CHPs, and peer-led in partnership, advise on best awareness channels within the community, facilitate friendly services for clients seeking HIV capacity building, etc. Commodity management. These tools must be updated on daily and monthly basis to avert data losses. These include the DAR, the MH642, the bin cards and stock control cards, laptop app forms, facility consumption data and reports and requests, that is the MH643B, HIV testing and prevention services, MH731, NC register, HIV lab testing and linkage register, expiry charts and temperature charts. I know you are conversant with all of these tools. This is the 643. Ukiangalia hapo kuna the oral, the HIV self-test oral and the HIV self-test blood-based. Then hapo chini kuna rapid hepatitis screening. So we should report on this starting this month to report hepatitis. The ones we received from KEMSA unaweka kwa hiyo column, quantity received from warehouse, e.g. KEMSA. Ile ya meds we put it as beginning balance because tumekuwa tukitumia, but ile ilikuja ya KEMSA tuweke kwa hiyo column ya KEMSA. Then another point to note is that the HIV self-test, the blood-based, is not replacing the oral test. The self-test for the oral, we love both. So you'll be providing to the client both the tests. So ana choose ile anataka. Kitaka ya blood unampea, kitaka ya oral unampea. So we'll be having both and reporting both. And I'm done. Back to the moderator.
Okay, thank you. Thank you very much, Mr. Mwisa, for that informative and enlightening presentation. I like the simplicity, the clarity, and the practicability of the presentation. And I think we now all understand what triple elimination is all about, and how it works in our setting, and the role that we play as a laboratory staff in the protection of our mothers and babies from HIV, syphilis, and hepatitis B. That is in the setting of the ANC. This time, I want to open the floor for comments